go to the practice site's website. There's a page for on ordering reports, and you designate which disciplines you want, which specialties you want, and what reporting period you want to have included. And then as you make those various sub-choices, those will print out on a report that you have. And you know that you can then just click on PDF, as is how this one was generated, which is just a PDF function, and then you have the PDF, which you can save, which you can email, you can send to others. I think you know also on the website where you have first generated this report, there is an Excel symbol there, and you can click on the Excel and you can download all the data that go into creating this report. So there are a number of states that have staff or collaborating units within with their office that have people who like to play with data, or there are other reports that the program, so they have to prepare for legislatures or whoever, and you have that data right there. That is your data, so you are welcome to use it, and a number of states we know are doing it. So next page is the first few graphs here, charts here, are to help orient you so you know who's in this report. And remember that these reports were created so that we melded in, merged in data from the 2012. That was a cross-sectional survey, so that's not officially part of this longitudinal data system, but that was good data, and we all worked hard to get that in, and so we drew that into this reporting system. So to the extent that there are items from the original questionnaire that can map well into the items on our current survey system, those data are brought in. So this tells you that this report here for Nebraska has 30 people whose information are brought in from the 2012 survey, and then there's another 15 or the 25 total who come in from practice sites. So they're actually people who responded to this automated survey or questionnaire system here. Because this report presents both information for people who are in the middle of their current contracts and they completed the end-of-year questionnaire, and then there are also people, clinicians whose data are here that are completing their contracts, and they therefore completed the end-of-contract questionnaire. This tells you how many of each groups there are here, and later on there are tables where in the title it tells you among people completing their contract, say this is how they reported, how they evaluated their loan repayment program. That then is referring to these individuals, because there are somewhat different questions between these two groups, as well as these groups and that group. Of course, you want to know descriptive statistics. Again, you want to know who is in this report. So here's a breakdown by disciplines. These are your 55 various disciplines, 55 individuals across the various disciplines. And then there's a table of specialties. And one thing to notice is that there are 55 individuals total, but there are not 55 individuals in specialties listed on this table. And the reason is only individuals who are in disciplines that have specialties are listed here. So a given, let's see if I can think on the fly, so various mental health. Mental health does not have specialties. They're different disciplines, but they're within mental health, but no specialties. So you see mental health is not included here, just specialties. And of the specialties, you see physicians. There are only 4 physicians. They're all family physicians, nurse practitioners, and these are the titles we use. Tended to be the titles that the disciplines themselves use in their national ways they refer to themselves. Clinician demographics. One thing to know is that we don't ask these questions on the end of year and end of contract questionnaire, but they are asked on the start of service questionnaire. But remember, these individuals each complete a sequence of questionnaires. So what this table shows is and would typically be data that's brought in for the individuals who completed their start of, rather their end of year, end of contract questionnaires, but brought in demographic information on them that they actually filled out at a different time, which was their start of service questionnaire. And this is standard, and the standard report, the standard format of many of these tables is to give raw accounts. There's 31 clinicians who were female, 14 who were male, and then also give you percentages, figuring sometimes they want to know it one way, sometimes they want to report it another way. Race ethnicity is here. Notice that the way the questionnaires ask Hispanic as an ethnicity, apart from how it asks about what race, therefore you can be white, non-Hispanic, you could be white, Hispanic, one could be Hispanic other, or African American black, and so the dashes mean there's nobody in those groups.
Oh, yeah.
Marital status, straightforward. Parenthood, now there are some questions that were not asked in the 2012 questionnaire, and so right now, particularly early in the retention module or the retention questionnaire, you'll notice that those for which the questions were not asked in 2012, which right now make up the majority of people in this report, the numbers can get very small, 4 and 9. We have very few people who don't complete questions on these questionnaires. People are doing a great job completing questions, but when you see low numbers like that, here's a couple asterisks. It means data is not available from the 2012 survey. The questionnaires we now have within the survey system, the questionnaire system, are much more complete. There are more items, and all of those items are shown in this summary report, but some of these items that will not have been asked in 2012.
She did say I'm not allowed to share it with you.
So there's someone with a unmuted phone. If you could all mute the phones, be good until you didn't speak. And again, I am welcoming questions, comments throughout this. Again, someone please mute your phone. Thank you. Continuing on, next section here is clinicians' work and where they're working. Again, this item is not available from 2012, so the numbers are somewhat smaller. This just asks the question, have they changed the service sites during the contract? Here's a description of the current types of practices. For work hours, we asked these separately, and people reported how much time do they typically do in a typical week for clinical work, for leadership administrative work, community work, etc. And I think you all know the difference between average, which is the same as mean, versus median. Median means what is the mid-person in the hierarchy in terms of what they report. So although on average there's 0.5 hours a week of community work, in the middle half of people are reporting none, and that's your median there. And then this tells you a little bit more how many people actually do report community work. That's 24%. 40% are teaching, 20% report other kinds of roles. This item, this question, number of nights and or weekend days on call each week is a question we've been using for literally decades now, and it works very well, and it seems to be very strongly correlated with any number of things, including burnout, as you might imagine. So it works well. So the maximum here, of course, would be 7 nights and weekend days a week. Among all clinicians, the average is just 1.3 nights on call a week. And median is 0, meaning half of people do not do any call. But remember, these are mental health folks and dentists and maybe some others who would not be doing call. And among just clinicians who do any call, their average is 2.7. I'm sorry. So this table, by the way, we've just figured out is an error in it. The average, this should not be percentage. This should be 1.3 days or nights. This should be 2.7 days or nights. So we will, I think that's actually already been changed now. But 2.7 nights on call a week is a lot for an average for those people, for the quarter of people who are doing call. If I don't hear people weighing in on if this, I mean, it would help me just to tell me if this approach, kind of going table by table, pointing out issues about the table, about some of the data, if this is helpful. And if it is, just a few people just let us know by typing it in or by reporting it, or if we should be focusing somehow differently on this data. Very happy to change.
Good to know when the percentages aren't reflective of percentages, so thank you.
What's that?
It's good to know when the percentages aren't actually a percentage.
Okay, I think that's the only one we saw of that. But going through these, since I hadn't looked at these in detail, I found a few other errors in there. So we'll be tidying up things here. So if some of those stumped you, please ask them, and I can hopefully let you know. As well as if you spot something we didn't see, we can go ahead and change that. That's pretty relatively easy at our end. Let's see. So continuing on, locations where clinicians provide care, and of course people can check as many of these as where they provide care. The data, we did not ask this back in 2012, so this is data from 25 clinicians, 23 are in the office, one's provides hospital inpatient, 2 in the ED, extended care, and 3 in other types of settings. This is the other one that has percentages that should not be percentages. So this should be number of patients encountered in a typical week. Outpatient clinic should be 46.3 visits. Encounters, not percentages. Same thing for the median here too. And you see the median, most people are a hospital or outpatient based, relatively little happening in other settings. But again, given the breakdown of the disciplines we're talking about, that shouldn't be surprising. There's only 4 physicians here, too. So curiously, we see a huge range of salaries for folks. An average median, the highest salary, $210,000. I would like to find out where that person works. But then down to $30,000 too. So this is a huge range. It lets us know that we're talking not about a uniform group of people making the same amount of money in the same job, but a great diversity of individuals, as well as what the support from participating in the National Health Service or a state program would mean something greatly different for these individuals. This is the distribution of the insurance type of patients. This is from clinicians. A similar question was asked also on the administrator questionnaire. They tend to be relatively close in data collection questionnaires of this kind, but this is from clinicians' perspectives. And just so you know, these percentages, if you add them up here, will total more than 100%, principally because some people have both Medicare and Medicaid. So this is not 100%. And for those of you who are eagle eyes, this pie chart was meant to present data here in the average column. But what you'll see, it says Medicaid here 2%, 42%. Here it said 44.5%. Here it said insured 22%. Here it said 23.5%. Reason is you can't make a pie chart with 107% total. At least I don't know how to do that. So in creating this pie chart, it reduced all these percentages so that their total was 100%. So that gives you an approximation, but it is easier to present to people as a pie chart, which is why we've included it there. Race ethnicity distribution is it does total to 100%. Again, the question is data not available back in 2012. You will see that we've asked the question a little differently for race ethnicity of patients rather than we asked of clinicians' own race ethnicity, in part because we figure people will have a harder time reporting how many, let's say, Hispanic African Americans they have among their patients. So we've simplified this for them here. This distribution here is the same as this average here, and the numbers are exactly the same, just rounded off. So white, not Hispanic, 55.9, of course, rounds off to 56%. So the previous work is tables is if you are presenting to your legislature, wants to know, well, where do your clinicians work? Who are they taking care of? Do they work hard? What are their settings? That's your descriptive information for folks. In section C, we're looking at more of the intermediate outcomes. Okay, how are they doing there? How do they regard their experience? The issue of satisfaction, all studies of retaining clinicians, which was a driving factor behind this entire data initiative, is very closely linked to satisfaction of individuals. If people are not satisfied in their community, in their jobs, in their practices, they are more likely to be taking off, of course. But the issues about satisfaction, how one typically approaches satisfaction when one is looking at, we're particularly interested in retention, but in general, employee morale, trying to empower and energize people working in any job, but certainly clinicians who are, as a whole, are very much mission-driven, are really trying to make an impact in their community and people's lives. It is important to understand not just, hey, are you happy, but are you happy in this way, are you happy in that way, and understand the specific ways that people are less than satisfied, and then trying to address those. So this question, the way this will present for any of your programs, this table, this graph is set up to automatically align them from the item, I fully value the mission of my practice, for which clinicians that are in this report, we most uniformly reported that they were satisfied or very satisfied, or rather, is they agree or strongly agree with the statement that I fully value the mission of my practice, down in order to those where they least agree with positive statements. So here, I am not well compensated given my training and practice. 30% agree with that. So I think you'll find it's easier to, if you show this graph, share it with people, draw a line around. This is where our clinicians are doing best in terms of their work and practices. Communities satisfaction comes on another graph later on, and this is, you say, where people are least satisfied. One strong caveat here is, don't assume and make a statement that, or invest money in saying, these are where people are least satisfied, therefore this is where we're going to put our money to improve, and this is where efforts are going to go to improve things. Because it turns out that there are any number of things that routinely are displeasing to clinicians, but everything that's displeasing, is not a reason for people to leave and go elsewhere. So we will, and this is something we will do as a group, is we will analytically look at these data and say, which of these areas of satisfaction prove a year and two from now and longer to be correlated with who's staying longer versus shorter. And that's been done in other studies too, and we as a group, if we should be sharing that information again to help us understand, then we surely should. But notions about mission and pleased with my work overall, strong personal connection to patients, those sense of belonging to the community, those are very important to retention. Things like not being well compensated, feeling that are less often associated with retention, in significant part because people just feel, hey, they're not going to get paid anywhere any better someplace else. Work really encroaches upon my personal time. That kind of comes along with the territory with many of these disciplines. Again, if people don't think it's going to be better somewhere else, or if it's just not important to them, even if they're dissatisfied in the area or not satisfied, they still won't be a reason for them to leave. And the classic one for this is paperwork. If you ask clinicians, how do you like your paperwork or how satisfied are you with that, that's in the very bottom of your list. I guess we didn't ask that here. But we all are giving up and saying, hey, no matter where we work as clinicians, we're going to have paperwork. So we're not happy about it, but it's not a reason we go someplace else.
Hey, Don.
Yes.
This is Tom. I want to go ahead and one of the things before when you were going over those, again, with Nebraska, we tend to have, some cases, especially looking here at the National Health Service Corps, some lower numbers, have a higher percentage of folks in the mental health field, but maybe not in some others.
Yes.
Doesn't make some sense then as far as states, when we go ahead and we look at our reports, could we, if we don't have enough people in a certain discipline or certain types of sites to feel like we're comfortable making comments, could we then as states go ahead and kind of combine data from our reports if we wanted to share that across, and then maybe ask you of how we might be able to use that information once it's combined for making statements and trying to share it with sites?
Absolutely. This information, the way these data sit, they absolutely can be used that way. We absolutely should be doing that. These standard reports are put together just as a way to readily bring out just a wide range of this data in a principally descriptive way for each of you. Now, of course, you can now, when you order the report, when you specify who's going to be in there, right now you can just specify it for mental health within each program, and you will get all of these tables showing just mental health there. And if you want to, you can in a clumsy way, but you can currently now also then produce a different report that, let's say, has your physicians, NPs, PAs, and then you can hold tables and graphs side by side and see what the differences are. What we are moving to doing this year, so sometime hopefully this spring, for this one questionnaire for these with the end of year and end of contract data, we will be making a new version of this that allows groups to be compared, so that you won't have to do that clumsy printing off for two different groups of clinicians and then holding them side by side. But actually each of these tables will be, so this graph here will allow for two groups to be compared, which might be those PAs, NPs, physicians as one group, and then mental health as another group, and have them, one group shown as a blue and next to them a red line, so you can see where the differences are for those two different groups. So for this year, we can, where we don't have much funds, I'm kind of limited at this point to what we can do, although we are trying to pull in more funds, which will increase what we can do even this year. But this year, I think what's doable is just to have two groups created within a given program that we can prepare, that you can then see compared side to side for this one report, the end of year under service report. It will not take much then to also compare across programs, but that will take more organizing and for the group so we understand when can others see your data and pull it into comparisons. How can we do it? And probably a good way to do that would be to compare one's own program, let's say mental health in one's own program against mental health in all other similar programs. So it might be all other NHSC loan repayments for all other states combined, in which case you're not seeing data directly for another state, in case some would find that sensitive. Although I've not seen much people very concerned about that with this group, which is great. Then, Tom, the next would be probably what you're suggesting, which is to be able to combine subgroups across programs. Each of these are doable, but as we're kind of looking at the work of this and how this develops, these are the kind of incremental things which give us more and more capacity over time. The other way to do it, I think you asked too, is right, which is right now we have all this data sitting here within the Chef Center, and my programmer can give me download a full file in a format that I can work with, and in fact we can produce his reports now anytime as ad hoc kind of reports, but we're not funded to do that right now, and so we'll be moving forward with that.
Okay, yeah, that's great. I mean, I was just kind of thinking in the meantime, if I had something where, for instance, if I was meeting with either community health centers and didn't feel like I had enough providers of certain type in there to share, that if I could talk to a couple of other states and see if they had information and what kind of responses were we getting back, and if they looked similar, that might help carry a little bit more weight when I was up visiting with folks at different programs, or even amongst, like, say, for instance, visiting with dentists or something along that line groups.
Good, certainly. I think you'll find, too, that yes, as you say, it is absolutely more convincing to anyone who's seeing your data to have greater numbers. I mean, none of us will trust if we had 8 mental health. We're not going to make much if they look a little different from some other group. But if you see 50 mental health or 300 mental health, then you start convincing people when they look different. The other way to convince people, which is even a stronger way, is to show that in the state of Nebraska, mental health on these items look better than other disciplines, and show that same relationship happens also in Arkansas and Alaska and California. What you see, that pattern can be even more convincing, which is, hey, there's something about mental health compared to others, and that happens in a variety of settings.
Thanks.
Good. Good question. Keep the questions coming. There are, notice that there's an item here that asks clinicians, would you recommend your practice to others of their discipline? So programs presumably would use this for feedback about particular practices that are now receiving loan repayment or scholarship participants, and being very concerned that it is unlikely and definitely not, and even 50-50, that's bothersome. We should think that any clinician participating in a program like this, we would want them to say at least probably they would recommend it to someone else, or definitely. So these areas are concerned. You will know who these individuals are because you have the data for those individuals, so you'll know what practice that is. Do know that this is recommendation of the practice. Later on, there's a question that asks, would you recommend your program, your loan repayment program, to others? So 2 different questions. The one on the program will be hidden so that you don't know who has rated what. And if fewer than 5 people have provided a rating on which you recommend your program to someone else, that you won't see that data, and that's to protect anonymity and to encourage people to be truthful about their loan repayment program. We figured it's important to know who said their practice is a problem, and the clinicians are not told that that's confidential. So here's positive statements about how their family and they are doing within the community. Important to know, and this is the same, organized the same as the previous satisfaction one, which is these are people who agree with various positive statements. We enjoy the activities that the community offers, etc. My spouse is happily employed. Spouses seem to have a difficulty, and National Health Service Corps studies have shown this for many, many years. I haven't even looked yet to see is this different for our state programs, but it very well may be. Note that these percentages here, they got asterisks. This excludes clinicians who are not married, have no significant other, or some of these exclude clinicians who don't have children living at home. So this is just among these questions that ask about spouses. Obviously, the percentages are just among married people. So So this should be, right now, the way this, this retention data system is set up, it is not meant yet to be surveying alumni. We are, in the coming few months, we will be designing the alumni questionnaire, looking for input from the group, and so that will be up and live. But right now, the people who are participating, providing information, are people who who have provided information initially while they're serving, and people who might have finished 5 years ago, let's say. The alumni questionnaire is purposely very short, just a page, so that we can get better completion rates of that. And remember, how long people are staying, we can then link back to this data that they provided when they were serving, start of service, and the end of year event and contract data. So we don't yet have retention information. We don't really know yet who in these various programs stayed. But the notion of anticipated retention, which is you ask the question, how many more years do you anticipate you will remain in ... and the questionnaire asks them in your current practice, in your current community, in a rural practice, and that only goes to people who are in a rural area and in a medically served area, whether you're rural or urban. And if people don't think they're in an underserved area, they're not asked that question. And then how long do you think you're going to stay in your current state? So this is the notion called anticipated retention. It's obviously their guess at this time, but the clinician's guess to this question turns out to be at least up to 5 years out, tends to be very, very predictive. If people say I'm leaving in the year, the vast majority of them will leave in about a year. And if they say they're going to stay 3 years or 5 years, that's at least 5 years, then that's pretty predictive of what they'll do. So this is your best outcome right now for retention. And if you look at these numbers, the mean number, that means the practices, these clinicians who are currently being surveyed at the end of 1 year of the NHSC loan payment service, or at the end of that service, their current time that they say that they are going to stay, more years they'll stay is 9.6 years for mean, which is your average, 5 years median, which means there's a whole bunch of people here who are saying 20 or 25 because the mean and the median are so different. And 25% only would say they anticipate they'll be gone 2 years after their beyond their current time, and 75th percentile. So more than 25% are saying, or 25% are saying they'll stay 20 years or more. And again, retention is not something one measures in just with respect to your current practice. There's many ways you can look at retention. States may look at this as saying, well, if this helps bring National Health Service Corps clinicians into the state and then they stay here afterwards, that is fantastic. And now you all should be saying this number is an error, and I think it is. Taking my notes for myself. The 75th percentile says 1 year, but if the median is 20 years, this has got to be over 20 years. So that's wrong. As you eagle-eyed people spot these, please send me notes so we can make sure we get any bugs out of these. Percentile error.
Thanks, Don. The other one I want to go ahead and comment on quickly is, for me, I guess that was kind of interesting too, with the anticipated retention of how reliable that is as far as being a good predictor. I think that's huge information for the rest of us to kind of know and be able to kind of put in the back of our minds and saying, okay, because again, everybody gets challenged with, what is retention, what's anticipated retention, but the responses that you're talking about, what we get back to that question to help generate this really is a very good indicator. So that's appreciated to know.
Yes, yes. I don't think if someone says they're going to be there 25 years and they're currently 31 years old, life changes. But particularly in the short run, within 5 years or so, people have a pretty good sense. And then what it tells you, if they say 25 years, it tells you they're not anticipating going there. Nothing they're seeing ahead of them that will take them away. That's their plan. Ultimately, I would suggest that the way we might understand best how to affect retention may be the fact that these numbers are more positive way out here than they will prove to be over time. But we will, over time, have the data that will let us say, what is it that predicts that someone will leave sooner than they initially thought they would leave? Because that then is a particular area of lost opportunity. And then we want to focus on those areas. This graph is the same as this line right here, the mean here. It's just showing it in a graph form, if that's easier or better for you to present. This table may be confusing for people. It will make more sense as we get accrue more and more people completing these questionnaires over time. But this is whether clinicians who are now completing their service contracts have fairly certain plans to leave their service practices or sites. And so that means there are fewer people who are responding. People who have responded to the end of your questionnaire, their data is not here because they didn't see this question on their questionnaire. But those who are completing their service saw this question. And they have fairly certain plans to leave their service practice. In this Nebraska cohort, 10 say no they don't, but 3 do have fairly certain plans to leave their practice. These next questions then are only for those 3 people going down here. So the type of next position is planned, parentheses, for those who are leaving their service site. So that's these 3 people are, one says they're moving to another clinical position, one says they're taking a teaching position, and one reported another reason. Anticipates remaining in the service state, so they're leaving their service site, but do they anticipate remaining in the service same state? 2 do not. 1 says that they're uncertain. And what type of setting do they anticipate they will work next? 2 say rural or small town, and 1 did not answer that question. So starting to get a little bit fine, but we figure, we've seen this in North Carolina where we get to ask the question, well, what happens to these people when they go? This is, right now, this is anticipated. Where do you think you're going to do? And these are people who said they are now have fairly certain plans to leave. So these people will be leaving. It would be, we would not expect them, in fact, to be staying. This section is then for clinicians reporting of their experience with their, in this case, NHSC loan repayment program. And are you planning to extend your contract? 15 said unlikely or not. 10 said yes. For those who said they're not asking, there's various reasons for not. So if you're a program that wants more people to be extending contracts, you've got your reason here. I won't have enough educational loans remaining. If this is a common reason and you want people to extend contracts, that speaks for the kind of program Alaska has one, and I just heard, saw information, I forgot what state, another state that's thinking of adding a direct incentive program, and that's for people who don't have loans, that they can just get other dollars, just direct dollar support. So in this case, almost half of the people who are not going to extend is because they don't have educational loans, but you can capture them with just direct incentive dollars. So this is one of those questions that is, these 2 questions on this page are ones that are responded to anonymously by the clinicians. Likelihood of recommending the NHSC loan repayment program to other clinicians. Only 1 said 50-50 and 12 say definitely. So that's an awful good showing for these folks. Then here's a mean rating of various aspects of that program, from 1 is poor to 5 being excellent. And again, these are arrayed by, automatically arrayed by where people are most satisfied to relatively least satisfied. And you see logistics and convenience, participation in the program overall. Again, these fare pretty well. And then, recognizing that you can compare groups, pretty soon we'll have a questionnaire that allows you to maybe people who participated, responded to these questions in 2013, compare it to the responses from 2014, compare it to 2015. If you've been working to, say, improve interactions with program staff, it's 3.9 now, and 4.5 becomes a collaborative target for all groups. This is how you can monitor, is that going?
Don, this is Mary. It might be interesting to see what happens with the reduction in the amount of service awards that the court has put in place now, to see how satisfied our clinicians are going to be in the future.
Yes. Programs education. So that the amount of financial support received through the program, of course. So that would be the one indicator you'd be following there, of course, Mary. If you were to look at retention beyond service terms, you would then also look at people who reported that they were not particularly satisfied in this. You can hold satisfaction with you can control for the satisfaction in other items and see how specifically or individually satisfaction on this item predicted how long people stayed. So yes. And I should point out, by doing this, too, many state programs have not been as generous as the National Health Service Corps has been. So as we all learn more about, say, for the core and how this is correlated with retention or people's other aspects of people's experience, that will also tell us, because that's one of the most common questions I hear is, how much should we be paying people? What should the level of support be? And right now, there's not much information to help guide us, but we're in line to have better data than has ever been had before. Overall satisfaction with the program, again, that looks pretty good. And again, this is this is completed anonymously. And again, for your own states, loan repayment programs or scholarship programs also completed anonymously. And then just another question that's a good retrospective and often used question is whether the program exceeded or fell short of initial expectations. And then, as you know, there were two questions at the end of this questionnaire that asked for suggestions for the staff, the service program, to help make the participation in the program better for clinicians. Another one asked for what can be done to help make retention longer, to help alumni continue to serve needy populations. I have been very impressed with the quality of the kinds of comments that people are providing to these questions. And they look very much like the kinds of things, hopefully you all will be finding ways, reasons, groups to be sharing this information with. And tables, graphs are one aspect of convincing people, having them give a sense of what's happening for a program. But if you can then give a quote that substantiates what the data are telling you, that really helps drive home the point.